Okay. Hello, everyone. We are so excited that you can be with us today for this wonderful webinar on kidney disease and cardiovascular disease. There is definitely a link between your kidneys and your heart, and we are joined with Dr. Bill Lombard today, who's going to talk to us all about it. First, we have some what we can call housekeeping items, things to know. All attendees are going to be in listen-only mode during this presentation. If you can't hear, hopefully you can see the screen, check the audio button on your personal computer or device to ensure your sound is on. This is most often the difficulty. Please type your questions into the Q&A box. You'll see a Q&A box. Please use that versus the chat box. It makes it a lot easier for us to answer your questions at any time during your presentation. The moderator will read your questions throughout the presentation, and there will be times where we'll stop for questions and we'll read some of your questions out loud. Questions about specific patient cases are only able to be answered by your treating physician. So we're not going to be able to answer real specific questions, but if you can ask it in a more general way, then we will try to get your questions answered. And a PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website. And we would like to thank our sponsor for this program, AstraZeneca, who was able to provide us with an educational grant to present this program here today. And I am Jody Smith. I'm the program director for the Mended Hearts, Inc., and I have the pleasure of introducing Dr. Bill Lombard. Bill is a retired nephrologist living in Bellingham, Washington. So he's over on the West Coast today, where he practiced since 1981. He dedicated his professional career for caring for patients with all forms and stages of kidney disease. Additionally, he was the medical director of the Mount Baker Kidney Center for more than 25 years. As a founding member of the Mount Baker Foundation, he has continued to work on improving the care and well-being of patients with kidney disease and promoting an understanding of its impact in the general population. When not working in the nonprofit world, he is flying and advancing his skills as a pilot and fly fishing for steelhead. So that's some pretty exciting stuff. And I am going to stop sharing my screen so Dr. Lombard can share his. Welcome, Dr. Lombard, and thank you so much for being here today.
Thanks so much for inviting me, Jody and Mandy, and thanks so much everyone for joining us today. I really appreciate the opportunity to talk to the Mended Hearts group. I've spoken to the Mended Hearts folks in town here in Bellingham several times, and I've always been impressed with the level of engagement of them as an audience, and always have been very interested and offered great questions, and it's always been a great experience for both of us. Let me start my screen sharing here, and we should be all set to go. To move this down. Okay. Sorry, I need to get a pointer up here as well. Okay. So today we're going to talk about the important role that kidney disease plays in cardiovascular disease, and also the overriding bigger picture that chronic kidney disease is a much greater problem throughout our country than most of us are aware of. And it's only by being aware of it, or being aware of our risk for chronic kidney disease and looking for it, that we can identify it early and treat it, which can oftentimes stop or at least slow the progression of the disease and hopefully prevent such individuals from going on to end-stage renal disease. It is a disease which is overly prevalent and underdiagnosed, and for this reason, awareness is really important. So chronic kidney disease has been called the silent epidemic, and it's been called silent for two reasons. One of them is that unlike diseases like diabetes or heart failure and other metabolic diseases, people with chronic kidney disease often have no idea that they have a disease process until late in its course. And consequently, we have to be aware of the risk factors, identify if we have them, and therefore look further. Secondly, it's called silent because it's a very much under-recognized disease, not just by the community as a whole, but also by medical personnel. It is an epidemic simply by virtue of its numbers, and we'll take a look at those now in more depth. So 1 in 3 of us is at risk for chronic kidney disease. So what does that mean? Well, if you look at a gallery on your Zoom call today, or Zoom webinar, you look to the person to your left and the person to your right, chances are that one of you has a risk factor for chronic kidney disease. And the question is, are you the one? So what do these numbers look like? Well, 15% of the US population, adult population, or 37 million people, are estimated to have chronic kidney disease. That's 1 in 3. The 1 in 10, only 1 in 10 know that they have kidney disease. 1 in 3 people with diabetes are likely to have chronic kidney disease. 1 in 5 with hypertension are likely to have chronic kidney disease. A really sad tale is that 1 in 2 people who have very low kidney function and are presenting for dialysis, but not yet on dialysis, still do not know they have chronic kidney disease. And the sadness of this is that those individuals then present for dialysis and what we call crash onto dialysis, requiring emergency blood access to be placed, which carries its own risk. They're not educated about the disease. They don't know what the diets are. And really importantly, they have missed the opportunity to get a preemptive live donor transplant, which most nephrologists would say that's sort of the penultimate treatment for chronic kidney disease. This experience is borne out in Bellingham at our kidney center, where routinely 40% of the dialysis patients that present for dialysis so-called crashed on having never having met a nephrologist or been involved in pre-dialysis education. Throughout the United States, every day, more than 360 people start dialysis. Any questions thus far that we'd like to address?
I don't see any questions in the chat box yet, but feel free to put your, go ahead, Jody.
I do have a question, even though they're not in the chat box. So to me, looking at these numbers, it's pretty alarming that all these people don't know they have kidney disease. And I know you're going to talk to us about risk factors, but are there really no symptoms whatsoever of having kidney disease?
You know, unless you have a kidney disease that is active within the organ itself, like recurrent kidney infections or kidney stones, most chronic kidney disease is not symptomatic, or the symptoms are so vague that most people don't pick them up until they get a blood test run. So the symptoms include fatigue, lack of appetite, and really that may be all that they may see, or they may begin urinating more at night, though many people do that, particularly as older guys, for many reasons. So we'll go over that and look at the risk factors, because it really is a matter of looking at the risk factors as to knowing when we need to start looking into this. Does that answer your question?
Yes, thank you. I started to get alarmed by it.
No, that's exactly what this is intended to do, is to pique our attention to say, how do I know if I have kidney disease? So first, let's talk a little bit about where the kidneys are, what they look like, and then what they do. So our kidneys are located in the back of our abdomen, up against the ribs, in actually a very sheltered position. The reason being that they're somewhat pedunculated, I mean, they're on the long ureter. This is the kidney, the ureter that goes down to the bladder. And if they were hanging free inside the abdomen, they would swing back and forth and various injuries could occur. So they're in a very sheltered position back there. Majority of us have 2 kidneys. About 1 in 700 births, however, is associated with what's called renal agenesis, where the individual has only 1 kidney. That kidney will function normally throughout that person's life. The kidneys are about the size of a fist, and this is a actual kidney which has been taken out of a person with normal kidney function and is being used as a donated kidney to a live recipient. Again, this is the kidney, this is the ureter. And again, we have two of kidneys, and consequently, not only is it good for the redundancy of function, but also it makes it very convenient for providing a live kidney to another individual who needs one. What do our kidneys do? Well, they do a number of things that we often aren't aware of. First off, they play a very important role in regulating blood pressure. The kidneys sense blood flow to them, and when they sense that blood flow is decreasing, they start secreting hormones like renin-angiotensin, which becomes angiotensin 2, which is one of the most potent hypertensive agents in our body. They also have a vasodepressor for high blood pressure, which plays a very minor role. The next important function is that the vitamin D that most of us take, which is 1-hydroxylated vitamin D, in the kidneys is converted to 1,25-dihydroxy vitamin D, which is the active form of vitamin D, which promotes absorption of calcium from our intestinal tract and also promotes the production of parathyroid hormone. Healthy bones are very much dependent upon the production of that active form of vitamin D. Another little known function of the kidneys is that they produce the hormone which directs the bone marrow to produce more red blood cells. They do this by a very delicate mechanism which actually senses the delivery of oxygen to these kidney cells, which then secrete erythropoietin, which then goes to the bone marrow and tells the stem cells to create more red blood cells. That in the absence of this, in the past, chronic renal failure patients have had severe anemias and suffered consequences thereof. We know now that hormone has actually been synthesized and has been used now for, 25, 30 years, and we can correct that anemia in most patients. The kidneys actually filter about 150 quarts of blood a day, and this is a little bit of a complex concept, but let me explain it this way. The kidney actually sees 25% of the blood flow coming out of the heart. That amounts to about 1,800 quarts a day. As that goes through the kidney, it has little filters, and those filters actually then produce 150 quarts of liquid that the kidney has to act on to reabsorb what it wants to keep and get rid of what it doesn't want. As you can imagine, if the kidneys weren't working adequately and we're putting out 150 quarts of liquid a day, we're certainly not going to last very long. But the kidney has a very precise mechanism whereby it absorbs water, sodium, glucose, amino acids, and calcium, and excretes potassium and phosphorus. In the process of doing that, it concentrates the waste products, substances like urea, creatinine, and a number of other organic acids, which are then excreted with the urine. And also in that process, it can determine how much fluid it should reabsorb. And it does that based on how it senses the body's fluid status to be. So when the kidneys are not getting adequate blood flow, or the blood pressure is low, they will reabsorb a lot more of the salt and water that's being filtered rather than letting it go out as urine. And it's a little bit complicated, but I think it's important to understand a little bit about that. So anyone have any questions about what kidneys look like or what they do, or any of these functions?
We have a couple questions. One is from Eugene, and he says, I have early stage kidney disease with slightly elevated creatine. Do you recommend limiting protein? And I don't know if you could speak to that since you're not his treating physician.
Right. Generally speaking, when we're in the past, limiting protein intake was a very important part of treating people with chronic kidney disease, because dialysis wasn't as widely available, and we thought we could delay the time before patients required dialysis. The concept being, if you take in a lot of protein, you have a lot of waste, the kidney has to work harder, and it will be sort of overworked and damaged by that. We found over time is that restricting people's protein ended up causing people to start dialysis with very low albumins and protein levels in their blood, which is not necessarily beneficial. So generally, we would not even consider restricting the protein intake until the eGFR, or we're going to say percentage of kidney function, is less than 20.
Okay, thank you. And then he also asks, does dialysis do everything that kidneys do? And I don't know if you'll get to that a little later on in the presentation.
We'll get onto that later on, and the answer is not quite. Nothing does as good a job as another kidney.
Okay, thank you. And one more question, how do diuretics affect the kidneys?
Good question. So this gets back to what we talked about here. Diuretics work by blocking some portions in the individual nephron segments of the kidney from absorbing salt and water, and causes us therefore to lose salt and water. It doesn't damage the kidneys as such in doing that, but it does cause the kidneys to have maladaptive changes. One of which is that as we excrete more sodium in one part of the kidney, it causes us to exchange more potassium, so we're at risk for lowering our potassium. It's at risk for shrinking our volume, which is the reason we're on diuretics. But if we overtreat with diuretics, we can shrink our volume. So they don't damage the kidneys as such, but by altering the volume status of the individual, it does change the perfusion of kidneys and can also result in potassium wasting. I hope that answers the question.
Okay, we do have a few more questions coming in. Some of them are around nutrition. So I just want to let the audience know that we will be having a CKD and CVD webinar that focuses just on nutrition on March 14th, I believe is the date. So I don't know if you want to wait until the end, doctor, to answer some of those nutrition questions, or
if you don't mind, let's do that, and we'll
yeah, that way we can get going.
I can.
Okay, thank you.
Okay, the important part, what are those risk factors that we need to be looking for that contribute to kidney disease? Well, the number one is diabetes. And if you look at the number of people going on to dialysis, virtually 60% of them have diabetes as a significant part of the disease. Often it is commingled with hypertension, but hypertension in and of itself is a significant contributor to chronic kidney disease. And heart disease it's estimated that if you take all comers with heart disease, 35% have some element of chronic kidney disease. And if you look at people with heart failure, it's as high as 60% of them will have stage 3 or 4 kidney disease. And we'll talk about those stages later. I'm sorry for introducing it early. Next, age over 60, there's a higher incidence of chronic kidney disease. If family history of kidney disease, particularly someone that has been on dialysis, is a risk factor for sure. Certain ethnic groups have a significantly higher incidence of kidney disease than the white population. African Americans are about 1.5 times the incidence of that of the white population. Hispanics are 1.3. Native Americans are about 1.2, and Asian Americans are about 1.2 as well. But those are significant differences. So if one were to be of one of those ethnic groups, I would definitely consider myself as being at increased risk, particularly if I had any of these other important factors. Tobacco use, there's a positive correlation between the development of chronic kidney disease and tobacco use. And then finally, a history of having had acute kidney injury. Let's say that one had a heart catheterization for an acute myocardial infarction. They came in with low blood pressure, and they had transient injury from the low blood pressure and the contrast injury, and then recovered mostly. Such individuals are going to be at an increased risk long-term for chronic kidney disease as well. These risk factors are important, so let's make sure that we get any questions answered about them now. And we'll stop again and ask if there's any questions to address.
Let's see. Nothing specifically about risk factors, no.
I do have one, sorry. I'm gonna keep asking questions. So I've heard a lot about anti-inflammatories like Advil or Motrin and risk of kidney disease. Can you speak to that? Does taking those kind of medications increase your risk of kidney disease?
I sure will. And you know what? We're to talk about that in the management of chronic kidney disease. Okay. Is that all right? Good enough to answer it that way?
Yes, that sounds great.
You're absolutely right. They are at risk. And the bottom line is if you have normal kidney function in normal doses for short periods, it's not a problem. High doses, long periods for anybody is a problem. For chronic kidney disease, any dosing is somewhat dangerous. Okay.
Thank you.
Okay. So we mentioned that there's a significant incidence of kidney disease just by virtue of having heart disease. And we're going to address that now. So very clearly, if you have kidney disease, it increases your risk of having heart disease. And there's a number of reasons for that, which we'll look at. But having heart disease also increases your risk for kidney disease. And you know, when you first think about it, you want to say, how does that work? That doesn't seem like heart disease should cause that problem. But there is, in fact, an intimate relationship between the two. The biggest one being that when the heart doesn't work, they don't pump adequate blood flow to the kidneys, and the kidneys are consequently injured because of that. So what do we know about this heart-kidney connection? Well, first off, we know that mortality is increased in those heart failure patients who do have chronic kidney disease. Hypertension is common to both of them and contributes to both of them. Heart disease and kidney disease share a common cause in a number of circumstances. Those individuals with diabetes certainly get premature coronary disease and premature kidney disease. Consequently, that's a connection. Kidney failure is associated with chronic fluid overload, which contributes, therefore, to congestive heart failure and continual stress on the myocardium, which then remodels and subsequently can fail. And it also accelerates vascular disease, and I'll address that a little later too, but it's also people with chronic kidney disease for a number of reasons very early on get coronary disease and peripheral vascular disease, largely because of calcification of the plaques in the vessels. Patients with chronic kidney disease have an increased risk for coronary disease for the reason I just mentioned and heart failure. And cardiovascular disease accounts for 50% of the deaths in people with chronic kidney disease. And this connection has been titled the cardiorenal syndromes. And then we'll take a closer look at those now. Definition of this is cardiorenal syndromes are broadly defined as the disorders of the heart and kidneys, whereby acute or chronic dysfunction of one of those organs may induce acute or chronic dysfunction in the other. So these two organs are intimately related. This is a little complicated, but we'll get through it together and look at what these cardiorenal syndromes are. In the first type 1, we have acute heart failure results in acute kidney injury. In this case, the kidney is the innocent bystander. In the acute heart failure, it's usually caused by acute decompensation, as might occur with a myocardial infarction, acute coronary syndrome. It happens in the low flow states when the myocardium is stunned after open heart surgery or after a percutaneous intervention, and is also contributed to by intravenous contrast dye, which may be used in those. That's type 1. In type 2, chronic heart failure causes progressive chronic kidney disease. And in this case, we're talking about, let's say, for example, chronic ischemic heart disease, where the person has had a number of small, maybe some large myocardial infarctions and loss of heart muscle, and they're in chronic heart failure. Over time, the kidney is less perfused than it's used to. It just does not get the same blood flow that it's used to. And additionally, if they start going into heart failure, they're given more diuretics, which further decreases their volume and further increases the injury to the kidneys. So you mentioned before, 60% of people with chronic heart failure have stage 3 and 4 chronic kidney disease. Type 3 is where the heart is the innocent bystander and an abrupt worsening of kidney function causes acute cardiac dysfunction, particularly fluid overload and congestive heart failure. An example of this would be someone who develops an acute inflammatory kidney disease, such as lupus, where the blood vessels are inflamed, or something called polyarteritis nodosa, or if they had acute kidney failure from a toxin, excessive amounts of non-steroidal drugs, as we mentioned earlier. The kidney stops working. It no longer can control the balance of fluids that we looked at earlier, and fluids accumulate and the person goes into pulmonary edema and acute fluid overload. So again, type 3, normal, the heart is the innocent bystander, or in this case, the kidney is the culprit. In type 4, chronic kidney disease contributes to cardiac dysfunction. So in people with chronic kidney disease, particularly those on dialysis, many of whom make no urine, in the period of time between dialysis is typically done 3 days a week. So it's about 48 hours during the week, but 72 hours on the weekend. Those people don't make urine. Every bit of fluid they drink goes into the body. And it's not uncommon for us to see someone show up for dialysis on a Monday or Tuesday morning that is 6 kilograms above their estimated dry weight. So that's 6 kilograms of water that the heart has had to pump around during that period of time. And consequently, the heart, just as it is fluid overloaded and becomes remodeled and damaged, and congestive heart failure is the consequence of that. Likewise, as we talked about earlier, there's an acceleration of vascular disease, which contributes to it as well. Type 5 cardiorenal syndrome are acute and chronic systemic disorders that cause injury to both the kidneys and the heart. Examples of this, again, would be diseases like lupus or polyarteritis, which are vasculitides, where the small to medium blood vessels are acutely inflamed and they swell and close. This can include the coronary arteries, can include the arteries in the small vessels in the kidneys as well. Of course, diabetes affects the blood vessels in the kidneys and the heart in patients that have this over a period of time. Diseases like sarcoidosis, a pretty uncommon disease, and certainly amyloidosis can also damage both kidneys and heart as well. Okay, that is a lot to talk about. I realize that. So let's see if anyone has any questions or wants further clarifications on these. But the bottom line is, when the heart's not doing well, the kidneys oftentimes don't. And when the kidneys aren't doing well, the heart's not doing well either.
So Dr. Lombard, Bill asks, how does a congestive heart failure diagnosis and stage 3B kidney disease balance the water intake? And are there any guidelines on this subject?
Boy, that is a great question. And it really depends on the particular individual and their ability to easily get rid of fluid. A general would be, if you take in a liter of fluid in addition to the amount of fluid you make a day, you will stay balanced. Maybe a liter and a half maximum. Most of us lose and have an insensible fluid loss from respiration and skin loss of about 500 to 750 cc's of fluid a day. So if you restrict your fluid intake to something in that ballpark, you can pretty much stay even. Obviously, when the fluid starts to go up, then additional diuretics may be required to control that. There are not any hard and fast guidelines, but again, that'll be a great question to talk with the dietitian about. And we'll look later on. And again, one of the key elements in controlling the progression of any of these is salt intake. You take in salt, your salt level goes up infinitesimally small amounts in your blood, which then still stimulate you to drink liquids. And that then leads to fluid overload. Did that answer your question, Bill?
I'll let him type that in. In the meantime, Alice had asked, and I think you kind of answered this, but how does the intake of water help with kidney function? And then how much water intake is recommended as a daily intake?
That's a good question. The way it helps is that by maintaining a normal hydration state, it keeps the blood volume at a normal level and keeps the kidneys perfused in the environment that they're used to. In terms of the absolute amount, again, if you were absolutely restricted and couldn't take in enough, you'd want to get in a minimum amount to cover your insensible losses, which would be a half to 3/4 of a quart a day. Otherwise, you're continually going downhill from there. That being said, most people recommend that 2 to 3 liters of fluid a day is a acceptable and good amount of fluid to take in. I would caution, though, that anyone with congestive heart failure, that needs to be run by your cardiologist. Some individuals, and as an adaptive response, not the individuals, the kidneys in those individuals, as an adaptive response, hold on to water more than they do sodium, and they tend to drive down their sodium levels and develop something called hyponatremia, which can have very serious adverse effects. So take that into account as well, please. Hope that answered your question.
We have a few more. Do you want to wait or do you want to answer those now, Dr. Lombard?
If you think there anything that's involving this, let's answer those now.
Okay.
But otherwise, we're going to go over
Sure.
how you treat and help stop.
Yeah. So the next one is about how to slow the progression, but this one I think is relevant. I have diastolic heart failure. What can I do to protect my kidneys from damage?
You know, I have to tell you that treating people with diastolic heart failure and chronic kidney disease in my practice, I found to be one of the most difficult things to do. It's always a balance between getting too dry and too wet. I mean, which is the problem with the stiff ventricle, where the ventricle during diastole doesn't expand very much, and it takes very little extra fluid to quickly end up in developing pulmonary congestion. A very tight rope of fluid balance, I think, for diastolic heart failure is the absolute best way to do it, and try to avoid being too dry, but on the other hand, staying free of symptoms.
Okay, I think that's it for those types of questions for now. Thank you.
Okay. This slide, this is going to be just a one-stop talk about this. Actually is one of my favorite slides, and it's complicated, and please bear with me as we go through it, and I think it'll make sense. What this slide looks at is cardiovascular mortality, and it's based on kidney function down here. This is eGFR, and we'll talk about that a little more later, but 90 would be normal. 60 to 90 is considered normal by many people. This is a hazard ratio. So as this goes up, when you go from 1, you're normal. 2, you'd be twice the normal risk. 4 times normal risk. 8 times normal risk. 6 times normal risk. And we're going to take first off this is individuals that have no protein excretion in their urine, or normal amounts, which is usually only 30 milligrams, a trivial amount. And as their kidney function declines, this is pretty minimal here, even at 60, you first see a tiny bump in their increased risk of cardiovascular mortality, maybe 1.3 times normal. As kidney function further deteriorates, now we get down to 15, and this is where we start looking, where people start being on dialysis. This now dramatically increases to a hazard ratio of 8 compared to other age-matched controls. So these other 2 lines represent people with increasing amounts of protein in the urine. And this guy up here is a group of people that have a lot of protein, multiple grams of protein. This guy had 30 milligrams. This person has 3,000 milligrams. It would be called what's known as the nephrotic syndrome, where it's a disease of the filters of the kidney where protein is lost excessively. Even when they have perfectly normal or supernormal kidney function, they're already at a 2.5 times the normal risk of cardiovascular mortality. And as they start losing kidney function, of course, it continues up. The reason for this is these individuals, when they're losing a lot of protein in the urine, also lose a lot of the other proteins in blood, including things like antithrombin 3, which prevents clots from forming. These individuals tend to get thrombotic events a number of different places, and certainly the coronaries are not saved from that. The second thing is that all of these folks here with end-stage renal disease, and the reason they have such a high ratio is they tend to have high levels of phosphorus in their blood, because phosphorus only is excreted in the body by kidney function, and that phosphorus complexes with calcium and tends to form calcification of the plaques and coronaries and in the cerebral blood vessels, as well as kidneys elsewhere in the body. So that accounts for that. But chronic kidney disease is a disease multiplier for cardiovascular disease. This is why, the other thing that happens with these people that have large amounts of protein excretion in the urine is they also almost all have some of the highest cholesterols I've ever seen in my career. Oftentimes have an LDL cholesterol of 250 and a total cholesterol of 350 to 400. So that obviously also contributes to that. Any questions about the disease multiplication effect of chronic kidney disease and cardiovascular disease?
No, nothing for this slide.
Okay. Okay, now that we've looked at all these risk factors, we want to go, well, how am I going to know if I'm the 1 in 3? First off, there's a very easy quiz that is on the National Kidney Foundation's website called minuteforyourkidneys.org. If you just type that in, go to it, there's like 6 questions, less than a minute, you have an answer, and it'll say you are at risk. And I took this test myself just to see what it did, and I kind of put in, okay, I said that I had diabetes, said I had hypertension, and they started sending me emails once a week to ask if I had checked in with my provider yet. So it's a great tool to find out what your risks are. If you looked at these risk factors and you say, yeah, I am at risk, then you need to discuss that further with whoever your doctor or your primary care provider is, or your cardiologist. There's 2 really easy tests to find out if you have kidney disease. The first is a urine protein to creatinine ratio. This gets back to that slide I showed you before. Protein levels of 30 and under indicate perfectly normal kidneys without evidence of damage to the filters or other areas in the kidney, but the filters in particular. The second test is the creatinine, from which is calculated the eGFR, and we'll have to spend a minute just talking about that. Creatinine is a waste product of muscle metabolism, and it's one of those substances that the kidney filters and leaves in the urine and then excretes it. When the normal serum level is usually, depending upon the lab, 0.7 to 1.2. And you kind of say, well, that's kind of a big range. Why is that? Well, if you're an 85-pound elderly person with not very much muscle mass, you're not going to generate much creatinine. So your creatinine level is going to be low. On the other hand, if you're a 25-year-old bodybuilder with a lot of muscle mass, it'd be very likely your creatinine is going to be closer to 1.2. But when you think about that, if that frail, small muscle mass individual comes with a creatinine of 1.2, something's wrong. And so there had to be a way to figure that out, and that was what's called the eGFR. Using the serum creatinine level on almost any chemistry screen, it can be a basic metabolic panel or a comprehensive metabolic panel, based on sex and age, they do what's called an eGFR, and GFR is that number we looked at on the bottom portion of the graph, which is expressed in mLs per minute. And normal would be 90 to 120. Below 90, it's not normal, but is still considered minimal injury. And once it gets below 60, we go on to another series of stages of kidney disease, which we'll look at in a second. So eGFR is a number to be very familiar with. You'd like to see this above 60. If it's not, you want to ask your doctor about that. And then if you have any of the risk factors, say, hey, I'd like a urine for protein to creatinine, please. And with those 2, you can very clearly identify if you have kidney disease. If you find you do have kidney disease, or you are the one at risk, be sure your physician or provider checks you regularly, checks your blood pressure, your creatinine, your eGFR, and protein in your urine. How often you're checked depends where you are. If you are in late stages, oftentimes I saw those patients weekly in my practice, people that had very mild elevations of their serum creatinine or minimal or modest elevations in their protein, I might see every 6 to 12 months, depending upon how stable they were. If you have progression of your numbers, your eGFR is going down, your creatinine is going up, and you have more protein urine, then you should be referred to a nephrologist, which is what I am, which is an individual who had, after internal medicine training, specialized in the treatment of kidney disease. And after that, your nephrologist should co-manage your care with your other providers, and you should notify them of any changes in your medications or any changes in your health status. Changes in medications is a tricky part of being a nephrologist. I would say that every day, at least 5 times, I looked up a medication to make sure the dosage didn't have to be significantly altered because of the patient's kidneys function. So we talked about progression, and the chronic kidney disease is typically a progressive disease. The kidney only has so many ways of responding to injury, and most of that tends to be scarring and narrowing of the blood vessels. So a scenario might be, let's say here I am, I'm starting off, I'm 30 years old, and all of a sudden I get some high blood pressure. Well, my kidney function is still normal, but I'm at increased risk. And let's say that I don't get treated for the blood pressure and I go along with high blood pressure for quite some period. Now I'm getting frank kidney damage. And as that progresses, I'm going to have advanced reduction in kidney function and finally kidney failure. The point being that untreated, if you don't slow the process in some way, the ongoing injury is progressive and goes to kidney failure that requires dialysis. Because this progressive change, kidney function has been staged, normal or having kidney damage but normal kidney function. Classic example would be someone that has perfectly normal kidney function but has a significant amount of albumin in the urine. Stage 2 is kidney function that's between 60 and 90 mLs per minute, or percent if you like, and that has mild kidney damage, or kidney damage with mild loss of function. Stage 3 is now more significant loss of function. Stage 3A, there's now stage 3A and B, and that's just based on this is broken up from 60 to 45, 45 to 30. This is probably the most common stage that we see out there in people with significant disease, but also is a place where you surely want to be putting into place everything you can to slow the progression. At stage 4 kidney disease, which is kidney function from 15 to 29, at this point, patients need to be talking about the possibility of a live donor transplant for when their kidneys fail, or are they going to choose dialysis? Because this is a late stage, and finally at stage 5, something needs to be done to preserve the life of the individual. So those are the 5 stages of kidney disease. Let me stop there and ask if anyone has any questions about that first, and then we'll go on to looking at treatment.
Harry asks, if someone with cardiovascular disease and diabetes but they adequately control their blood pressure and glucose with medication and exercise, does this significantly reduce their kidney disease risk?
Absolutely does. Absolutely does. And we're going to talk about that in a bit, but there's no question I have seen people that have had 45 years of insulin-dependent diabetes who have normal kidney function because they did a great job taking care of themselves.
Okay, great.
So that's absolutely so.
And Sam just asks, does the GFR, did it used to be calculated differently? He wondered, that was his question.
It did. There were 2 things that changed. First off, it used to be calculated based on a 24-hour urine collection. And what we found is that, or what the nephrology community found over time, is it's actually more accurate to calculate it based on the serum creatinine. Just in the last year, maybe year and a half now, race was removed as part of the calculation of kidney function. It was felt that for any given creatinine level, people with the Black race actually had, African Americans had a higher kidney level function than others. And consequently, they didn't get referred until much later in the disease. And also, there was a sort of a built-in, unfortunate systemic racism, which delayed the referrals for kidney transplants as well. That has been removed, and I don't think there's any calculators now which use race as one of the discriminators in that. I hope that answers Sam's question. Okay.
Yeah, that's everything for now. Thank you.
Okay, let's talk about what we can do so we can lower our risk for progressing to kidney failure. So we've identified that we have a risk. We want to mitigate those risks as best we can. And if we have, that's before we even get chronic kidney disease, but if we have kidney disease, and we want to do what we can to take care of that. So first off, seeing a nephrologist will be helpful, because there are some types of kidney disease which require a very specific treatment. This might be kidney disease related to multiple myeloma, kidney disease related to various forms of inflammation in the filters of the kidney or the blood vessels in the kidney. So that's something for the nephrologist to determine, which would be what is the cause of my kidney disease, and does it require specific treatment? Second of all, if the patient has, if that individual has blood sugar problems, you want to target the control as best you can. Usually people say an A1C hemoglobin around 7, but depending upon the therapies that are being used for that person, that can vary significantly. When you start getting close to 7, you increase the risk of having, if you're taking insulin, you increase the risk of having hypoglycemic episodes, which are very troublesome for patients and dangerous. Next is controlling blood pressure. And I have a range here that's pretty wide, 120/70 to 135/75. And this is based on the SPRINT trial, which was completed a couple years ago. What it found was that in those people with large or high levels of protein in their urine, a lower value would decrease that protein excretion and extend their lives and extend the life of their kidneys. If you don't, when they were compared to the individuals with standard care, which was 135/70, these individuals, if they had high levels of proteinuria, had an accelerated progression to kidney failure. If you do not have high levels of proteinuria, there was no difference in mortality and no difference in progression to kidney disease. That being said, if any of you individuals with cardiac disease are told by your physician, by your cardiologist, to have a specific level, that's what you want. That's what you want to target. Okay, how can we further lower the risk of progressing to kidney failure? Well, eating healthily, particularly a low-salt diet, is very important. As always, the lifestyle changes of exercise and controlling weight are critically important. Here we're getting to avoid medications and exposures that can harm kidneys. Mentioned this briefly, but so ibuprofen and Aleve, as I mentioned, if you have normal kidney function, chances are you can take this with little impact. If you take it in high doses for prolonged periods of time, it will damage kidneys. And in people with heart failure, I can tell you, if you take ibuprofen, Aleve, or any of the non-steroidal drugs, you will develop some fluid retention and your blood pressures will go up. So they are definitely on the list of things you want to avoid or try to work around if you can. Some antibiotics, particularly sulfa drugs, can damage kidneys, and the dosage has to be significantly reduced for people with impaired kidney function. Omeprazole, Prilosec, Lansoprazole, all of the acid-reducing drugs. Now, there's a very low incidence of allergic kidney disease. That is, it's called allergic interstitial nephritis, where you actually have eosinophils or allergy cells sort of infiltrating the kidney and reducing function occurs in a very small percentage of these people, but there's a huge number of people out there taking the acid suppressing drugs. We are still seeing in Bellingham about 6 or 7 people a year who have an impairment in their kidney function because of this. When it's removed, they generally get better, but it is something that if you're taking those and you have an elevated creatinine, it's a good idea to say, can I try changing this to something else for a while to see if my kidney function improves? Any supplement, if you have chronic kidney disease, should be run by your nephrologist or your primary care provider. And then, as we mentioned before, intravenous contrast that is used for heart catheterizations, CT scans, and like can definitely be damaging to kidneys if you have kidney insufficiency. If you don't have any evidence of kidney disease, chances are it'll cause no problems whatsoever. Smoking has been shown to be, as we mentioned earlier, associated with progression of kidney disease. Urinary tract infections, if one is so predisposed to them, need to get those treated early, because if they actually go from bladder infection to actually infecting the kidney, almost always there's a little chunk of kidney function that ends up being damaged because of that. There are drugs that are specifically used to slow the progression of chronic kidney disease. The ACE inhibitors, like lisinopril, and a host of other drugs, losartan, likewise, tamosartan, these drugs were shown long ago to preserve the life of kidneys that have been injured. In regards to that, one of my memories in my practice was a young woman who I met my first year in practice. She was 22, had her first child. She was an insulin-dependent diabetic from age 5. At the terminal portion of her pregnancy, she had acute kidney failure, was massively fluid overloaded. She delivered the baby, and over time, with the use of an ACE inhibitor, at the time was captopril, similar to lisinopril, we controlled her blood pressure, her protein in her urine slowly decreased, and she lived. I last saw her when she was in her 50s, and her kidney function was still, though not normal, was nowhere near requiring dialysis. So these drugs work, and I've saw that many time over time in my practice. The aldosterone receptor antagonists like finerenone or spironolactone can also slow the progress of kidney disease. Very importantly, recently in the liver trial, this just came out in September of 2022, the drug dapagliflozin or Farxiga, which is a sodium glucose co-transporter, which the way this works is it actually blocks the co-transport in part of the kidney where sodium and glucose are transported together. It blocks that, so you have more glucose and more sodium in your urine. Significantly reduced the incidence of hospitalizations in people with congestive heart failure by 30%, and decreased mortality by 18%. So, and compared to controls that did the same people that were also on ACE inhibitors and similar drugs, similar amounts of diuretics, but with the addition of this drug, there was a substantial improvement. And finally, it's important to treat anemia. As I mentioned before, because the kidney makes the hormone to stimulate red cell production, anemia is associated with chronic kidney disease now, can be treated. It usually requires some iron replacement, but also the use of several drugs now, erythropoietin, darbepoetin. They get down to a frequency of administration, even a sub-Q injection once a month, and maintain good levels of red cells. So again, a lot to digest there, but let's go ahead and see if anyone has any questions about things we can do to slow the progression of our kidney disease.
Sure, and we've got just 5 minutes left, so we'll get through these. Does low blood pressure have a negative effect on the kidneys?
I'm sorry, can you say that again?
Sure. Does having low blood pressure have a negative effect on your kidneys?
Low blood pressure? It
Yeah.
certainly can. When the blood pressure is low, the kidney is not adequately perfused. If your blood pressure is low in the absence of medications, generally that's not a problem, unless it's associated with a chronic volume depleted state from some other cause like diarrhea.
Okay. Does monitoring one's daily weight for changes have an impact? Like, is that important?
I'm sorry.
Is it important to monitor your daily weight for change?
Absolutely, because that's the best way to follow what your fluid balance is doing. Any day-to-day weight change of 1 pound, 2 pounds, 3 pounds or more are always related to fluid balance. And obviously we don't want to go too much higher in our fluid because our blood pressure goes up and then we increase congestive heart failure symptoms.
Okay. I'm gonna probably not pronounce this correctly, but is omeprazole, omeprazole, it's a medication, it looks like. Is it okay to take that if you don't have kidney disease, but you do have heart disease and a problem with fluid overload?
I'm not familiar with that.
Okay.
By that name, so I can't.
Okay. You can't comment. That's great. That's fine. Sodium glucose transporter drug names. Linda, I'm sorry, I'm not sure what your question means. I apologize. Sam asks, could diabetes post-transplant lead to kidney failure or damage?
I'm afraid it can. Usually it's recognized early and treated early and treated aggressively, but unfortunately it can. The drugs we take for transplantation do unfortunately cause insulin-dependent diabetes in some folks.
Okay. I have a question that came up earlier. It's not specifically about this, but Linda asks, how do you know if you've received an injury from a kidney injury from a heart cath? I assume you just go check with your doctor. Is that?
Yeah, serum creatinine levels, the creatinine would go up.
Okay, thank you. And I think that's it, other than nutrition questions, which, like I said, I put the registration info for the nutrition webinar on March 12th in the chat box. So, but I believe that's it for now.
Okay, we'll just finish up here then. Okay, long-term treatment of when kidneys fail. Transplant is ideal. A living donor before dialysis is best. The kidney is actually a live donor kidney before someone's ever on dialysis lasts longer. We actually have an initiative going locally and around the country to increase the awareness to being a live donor. Dialysis can be done at home, which show this individual here where blood is taken out, cleaned and returned. Can be done at home. It can be done in centers. Can also be done in the peritoneum. And finally, palliative care is a good option for those frail elderly folks because they actually tend to do better when they don't even go into dialysis. They spend more time at home, less time in the hospital, and actually have better symptom control. Just quick facts about end-stage renal disease. As of 1919, there were 132 people started. We talked about this earlier. It's about 300 some a day. 750,000 are on dialysis or living with a transplant. Every day, more than 360 people start dialysis. Unfortunately, also more than 240 people that are on dialysis die, most due to heart attacks, strokes, or cardiac arrest. We talked about before about African Americans and Hispanics. Summary. Kidney disease risk and prevalence is much greater than most of us are aware. Cardiovascular disease increases our risk of having kidney disease. If you have kidney disease, you're also more likely to have heart disease. Finding out if you're at risk and to have or have signs of kidney disease is important and easy by taking just a urine test and blood test. It is very important to find out early and treat early to prevent or slow the progression of chronic kidney disease and associated its associated heart disease. I would recommend this site. All these sites are good. I don't know if there's a way to make that available to folks otherwise, but the CDC has had a big push for the last year in educating the population about kidney disease. Okay, we're taking additional questions now if you like. I'm sorry I hurried through the last part, but I think it was just, those are just quick summary things.
I don't see any, no more questions specific to your presentation. Thank you.
So what I will say is this is my email. If any of you have questions you want to address to me, I'm perfectly happy with you send them to me. That does not bother me. I'm retired and enjoy talking about anything that can help other individuals.
Well, thank you so much, Dr. Lombard. This has been such an informative presentation, and I know that our members are as appreciative as we are for you taking the time out of your busy schedule to help inform and educate us.
You bet. So I was happy
Yes,
to do.
thank you so much. We really appreciate it.
Okay. Take care now.
All right,
Have a good
bye.